مساء الخير جميعا. طبعا يشرفنا النهارده ان احنا نستأنف النشاط العلمي المميز للجمعيه المصريه للامراض وزراعه الكلى، اللي هو الحقيقه بتعمل اكتيفيتيز ساينتفك مستمره على مدى الشهور الماضيه. والنهارده احنا عندنا specific program of kidney care management بالتعاون مع شركه سانوفي، وهنتكلم على موضوع يهم النفرولوجيست كلهم، وهو الانتيكوجوليشن النفرولوجي. انتيكوجوليشن طبعا زي ما حضراتكم عارفين هو من الحاجات الفيري امبورتنت في النفرولوجي براكتس بجميع انواعه، سواء كنا بنتكلم على الموداليتيز اوف دياليسيس بانواعها، او بنتكلم على الامراض التي تحتاج في علاجها للانتيكوجوليشن، او بنتكلم في المرحله الاخيره او الشهور الاخيره لما ذكر ان الكوفيد نفسه ممكن يبقى له اكسس ثرومبوتيك تندنسي ويحتاج في التريتمنت بتاعه للانتيكوجوليشن. وعشان كده احنا النهارده معانا 3 important eminent speakers، وبشرف كمان معايا بالكو تشير الاستاذ الدكتور حسين شعيشه، استاذ امراض الكلى بالمنصوره ورئيس شعبه التعليم الطبي المستمر في الجمعيه المصريه. ومعانا 3 جريت سبيكر، استاذ دكتور منتصر زيد، والاستاذ دكتور سامح ابو زيد، والاستاذ الدكتور محمد صلاح. وادي الميكروفون للاستاذ الدكتور حسين شعيشه لبدء الاول تقديم. اتفضل.
في البدايه طبعا سعيد جدا بوجودي مع حضراتكم، وفي وجود طبعا استاذنا الدكتور هاني حافظ رئيس الجمعيه. النهارده زي ما الدكتور هاني قال الموضوعات كلها شيقه جدا والسبيكرز على اعلى مستوى. So it's my pleasure and honor to introduce first speaker, Professor Muntasir Zaid. He is a well-known figure. He is a professor of medicine and nephrology at Alexandria University, and you enjoyed attending NephroAlex last week. It was a fantastic meeting run by the high-tech hybrid technology, and I would like to appreciate the efforts of ICOM for running this meeting, to have professors from everywhere, from the United States and Europe, plus the Egyptian figures. So this night, Professor Muntasir Zaid will give us a talk about anticoagulation protocols in hemodialysis. I think it will be very exciting, and Professor Muntasir will deliver a very exciting topic. Professor Muntasir.
Thank you, Professor Hussein, for your nice introduction. Our agenda today is an short introduction. Heparin-related modalities as unfractionated heparin, low molecular weight heparin, heparin-free dialysis, regional anticoagulation with protamine reversal, heparin-coated filter, citrate-related anticoagulation as regional citrate anticoagulation, citracate, and others as heparinoids, direct thrombin inhibitors, platelet inhibiting agents, and the anticoagulation selection. Clotting in extracorporeal circuit occur predominantly as a result of activation of platelets and the coagulation cascade. 2 coagulation pathways exist: the intrinsic or contact pathway, which starts with activation of factor 12 and the high molecular weight kallikrein, and the extrinsic pathway that is initiated by the activation of factor 7 by tissue factor thromboplastin, which results in activation of factor 7, and then activated factor 7 will activate factor 10. The intrinsic pathway starts by activation of factor 12, and then this will lead to activation of a series of coagulation factors, till factor activated factor 10, which converts prothrombin to thrombin. Prothrombin is a factor 2, and the prothrombin is activated factor 2. Factors affected by heparin anticoagulation are colored red and vitamin K dependent factors affected by oral anticoagulants are colored by the red color. The available anticoagulants used in vivo, parenteral anticoagulants as indirect thrombin inhibitors, heparin, low molecular weight heparin, fondaparinux, danabaroid, and direct thrombin inhibitor as heroidin, and oral anticoagulants, which is not the subject of us today, and anticoagulants used in vitro as heparin and acid citrate dextrose solution used in blood anticoagulation. Heparin as a prototype is the strongest organic acid present in the body, present in mast cell, molecular weight 75,000, present in lung, liver, and intestinal mucosa, commercially available from ox lung and the big mucosa, chemically non-uniform mixture of chain mucopolysaccharide, molecular weight from 10,000 to 20,000, and carries the strongest electronegative charge. Of two types, regular or unfractionated heparin, molecular weight from 5,000 to 30,000, which can be administered by intravenous or subcutaneous route, and low molecular weight heparin, molecular weight from 2,000 to 6,000, and mostly given subcutaneously. Heparin acts by activation of plasma antithrombin 3. Heparin antithrombin 3 complex inactivates clotting factors 10A, 2A, 9A, 12A, and 13A, but not through its extrinsic pathway. At low concentration, activated factor 10 mediate conversion of prothrombin to thrombin, and overall activated 10 and activated factor 2 mediated conversion of fibrinogen to fibrin. Inhibition of factor activated 10 needs only the two mechanisms, low molecular weight heparin, fondaparinux. Factor 2 activation needs both the mechanism, antiplatelet action in high doses prevent platelet aggregation and prolongs bleeding time. It also, heparin has an act upon lipemic clearance. The adverse effects of heparin are bleeding due to overdose. Hematuria is the first sign. Thrombocytopenia as a result of aggregation of platelets. Hypersensitivity reaction as urticaria, rigor, fever, and anaphylaxis, alopecia, and osteoporosis. It is contraindicated in bleeding disorders, severe hypertension, GIT ulcer, biles, subacute bacterial endocarditis and malignancy, ocular and neurosurgery, chronic alcoholism and cirrhosis. Aspirin and the antiplatelet drugs should be used with caution in presence of heparin. The low molecular weight heparin from 2,000 to 6,000 Dalton acts by interfering with activated factor 10, inducing conformational change in antithrombin 3. It has a smaller effect on activated partial thromboplastin time, whole blood clotting time, lesser antiplatelet action, and lower incidence of hemorrhagic complications, better bioavailability on subcutaneous administration, better half-life from 4 to 6 hours, laboratory monitoring not needed, activated partial thromboplastin time and the clotting time affected little by low molecular weight heparin. Prosulfate acts as a heparin antagonist given intravenously, 1 milligram, and antagonizes 100 units of heparin. Patients on hemodialysis are at risk of both bleeding tendency and thrombosis. Bleeding results from uremia-associated platelet dysfunction, endothelial abnormalities, anticoagulants on hemodialysis. Thrombosis results from systemic inflammation, diffuse endothelial damage, decrease in level of protein C and S, antithrombin 3 level also, hemodialysis filters and line, turbulent blood flow and higher shear stress during hemodialysis, leukocytes and platelet co-aggregation, and high hematocrit and blood transfusion during hemodialysis. Heparin and administration methods. We have 3 methods for administration of heparin during hemodialysis. At first, method 1, routine heparin administration by initial bolus, followed by continuous infusion method. Method B, routine administration and then repeated bolus method. Method 3, which is tight heparin administration by continuous infusion method. The routine heparin infusion intermittent hemodialysis in a dose of an initial bolus dose of 50 international unit per kilogram, around 2,000 international unit administration as a bolus dose, and then infusion in the range from 800 to 1,500 international unit per hour, in the range of 1,200 international unit per hour. For continuous renal replacement therapy, 30 international unit per kilogram from 2,000 to 5,000 international units, and then we start infusion by a rate of 500 international unit per hour, and then to a target of activated partial thromboplastin time from 45 to 60 seconds. If this target is less than 45 seconds, then we can increase the dose of 500 by titration up 100 unit per hour till we reach the target dose. And if it is above 60, we can reduce the dose below 500 international unit per hour. Heparin monitoring results in routine heparin dosage during dialysis to be 2 to 2.5 activated partial thromboplastin time, and at the end of dialysis to reach 1.5 to 2 activated partial thromboplastin time. Stopping heparin infusion starts 1 hour prior to the end of dialysis and will result in the desired clotting time at the termination of the session. In practice, heparin therapy is ordinarily prescribed empirically without monitoring of coagulation. In patients who are at an elevated risk of bleeding, the need to monitor anticoagulation is often circumvented by use of heparin-free diets. The second method is routine heparin administration as an initial bolus and then repeated boluses every hour. We start by 2,000 international unit as an initial bolus dose, and then 1,000 international unit as the start of second hour, third hour, and the fourth hour. Tight heparin constant infusion method is recommended for patients who are at slight risk for bleeding, when the risk of bleeding is chronic and prolonged, and if the use of heparin-free dialysis has been unsuccessful because of frequent clotting. For tight heparin control, we keep activated partial thromboplastin time at 1.5 to 2 times normal, and to be kept as such till the end of dialysis session. For tight control, at first we obtain a baseline clotting time, initial bolus dose of 750 international unit, recheck clotting time after 3 minutes, and if we reach the desired clotting time, start dialysis and the heparin infusion rate at a rate of 600 international unit per hour, and then monitor clotting times every 30 minutes. If we did not reach the desired clotting time by this initial dose, then we administer a supplemental bolus dose and then continue with continuous heparin infusion. We continue heparin infusion in the tight protocol till the end of dialysis session. Factors favoring clotting of extracorporeal circuit during hemodialysis are low blood flow, high hematocrit, high ultrafiltration rate, dialysis access recirculation, intradialytic blood and blood product transfusion, intradialytic lipid infusion, use of drip chamber as a result of air exposure, foam formation, and presence of turbulence. The complications of heparinization at first bleeding, incidence of bleeding ranges from 10 to 50%, mortality due to bleeding as high as 15%, risk of bleeding is proportional to the activated partial thromboplastin time and not to heparin dose. Don't blame heparin as the cause of post-therapy bleeding. Post-therapy needle puncture site bleeding, we have to re-evaluate heparin dose. Vascular access should be evaluated for the presence of venous hypertension and the evaluation of needle insertion technique. Heparin-induced thrombocytopenia, we have 2 types of heparin-induced thrombocytopenia: HIT, in type 1 HIT, reduction in platelet count occur in a time and dose-dependent manner, and the response to reduction in heparin dose. In type 2 HIT, there is agglutination of platelets and the paradoxical arterial and or venous thrombosis. type 2 heat, which is attributable to the development of immunoglobulin G and M against heparin platelet factor 4 complex, is more commonly induced with bovine versus bovine unfractionated heparin and less with low molecular weight heparin. Given the frequency of heat in the non-dialysis population, it is surprising that it is not encountered more often in a dialysis session. The alternative anticoagulant of choice, including the direct thrombin inhibitor argatropan and the heparinoid danabaroid. Low molecular weight heparin should not be used to treat heat because there are often cross-reactivity of the heparin platelet factor 4 antibodies with these drugs. Other heparin-associated complications are lipids, increased triglyceride and decreased HDL, hyperkalemia induced by suppression of aldosterone synthesis, pruritus, anaphylactoid reaction, first-use syndrome, which can also occur with low molecular weight heparin, osteoporosis, and alopecia. Low molecular weight heparins have a longer half-life, more rapid onset of action, higher bioavailability, and more predictable effect. It has a less non-specific binding to endothelium, plasma proteins, and platelets, less platelet and leukocyte activation, and fibrin deposition on dialyzer surface. And it has also, it could be counteract, we can counteract its action also by glutamine sulfate. Low molecular weight heparin has less risk of heparin-induced osteoporosis, less thrombocytopenia, but heat can occur, less hyperkalemia, less disturbance of lipid profile, anaphylactoid first-use syndrome. Although unfractionated heparin has been the mainstay therapy for extracorporeal anticoagulation for many decades, low molecular weight heparin has now replaced unfractionated heparin as the anticoagulation of choice in many European countries. A comparative study between low molecular weight heparin versus unfractionated heparin, safety and efficacy of low molecular weight heparins for hemodialysis in patients with end-stage renal disease. Mean difference for bleeding assessed as vascular access compression time was in favor of low molecular weight heparin over unfractionated heparin. Also, safety and efficacy of low molecular weight heparin for hemodialysis patients. Relative risk for extracorporeal circuit thrombosis are in favor more for unfractionated heparin over low molecular weight heparin. The European best practice guidelines for use of low molecular weight heparin, level C recommendation. The use of low molecular weight heparin is to be preferred over unfractionated heparin. Most commonly used low molecular weight heparins in Egypt, tinzaparin and enoxaparin. Longer half-life permits anticoagulation with a single dose at the start of dialysis. If we use the extended daily dialysis, we can split dosing, which will be better for a dialysis session more than 8 hours. Commonly used low molecular weight heparins for CRRT dosing, dalteparin 20 unit per kilogram bolus dose and infusion 10 unit per kilogram per hour. The objective for anticoagulation for CRRT is to maintain filter patency over 24 to 48 hours. Citrate anticoagulation is more recommended for CRRT. Citrate binds calcium to form a complex that is readily removed by diffusion during dialysis, and with prolonged infusion, particularly CVVH, citrate toxicity is common and lead to hypocalcemia, hypomagnesemia, hypernatremia, and metabolic alkalosis. 4% trisodium citrate solution containing citrate 140 millimole per liter can be infused into arterial line, and hypocalcemia can be avoided by adjusting calcium concentration of dialysate and or the replacement fluid. And this figure demonstrates CK pump, one pump for citrate infusion and the calcium infusion at the end of dialysis circuit, what we call local anticoagulation. Generally, low molecular weight heparins are not widely used in CRRT because of a very prolonged half-life and may be associated with a high risk of bleeding. Monitoring of low molecular weight heparin with activated partial thromboplastin time is not accurate, and the measurement of activated factor 10 level provided a better indication, but not readily available. Heparin-free dialysis is indicated in pericarditis, recent surgery, coagulopathy, thrombocytopenia, intracerebral hemorrhage, active bleeding, routine use for dialysis of acutely ill patients by many centers and persons with heparin allergy. For heparin-free dialysis procedure, runs extracorporeal circuit with saline containing 2,000 to 5,000 units of heparin, and this step is optional and if avoided if there is heat complication, and drain heparin containing priming fluid by unheparinized saline, and then set blood flow rate at 250 to 500 milli per minute. Periodic saline flush or rinse with 50 to 250 milli of saline every 15 to 30 minutes. Allow inspection of a hollow fiber dialyzer for evidence of clotting. Continuous saline infusion can be used as an alternative to coagulation during dialysis. Utilizing this technique, saline is administered to extracorporeal circuit continuously throughout dialysis session at a rate of 200 milli per hour. Regional anticoagulation with glutamine reversal is technically difficult and rebound bleeding 2 to 4 hours after end of dialysis. Heparin-coated filters, heparin-coated polyacrylonitrile membrane versus regional citrate anticoagulation, prospective randomized study of 2 anticoagulation strategies in patients at risk for bleeding. The coated membranes were associated with significantly increased incidence of membrane clotting. Heparin-grafted membrane Ivodial from Gambro have a better success in heparin-free dialysis with continuous saline infusion and intermittent saline flush. Regional citrate infusion versus heparin anticoagulation, randomized Crohn trial may reduce risk of bleeding, increase circuit patency, and reduce neutrophil and complement activation. For patients without increased risk of bleeding, KDIGO guidelines recommends for anticoagulation in CRRT. We suggest using regional citrate anticoagulation rather than heparin in patients who do not have contraindication for citrate. Citracate is a new innovative dialysis acid concentrate in which 3 millimole of acetic acid have been replaced by 0.8 millimole of citric acid along with 0.3 millimole of acetate. Using citrate containing dialysate result in reduction of heparin dose by about 55%. Further studies are needed to delineate the role of citric acid-based dialysate, and it is commercially actually available. Heparinoids act by acting against anti-factor 10, activated factor 10 as fondaparinux, and this is primarily used in management of heat. Argatropan, recombinant heroidin, act as an antithrombin. Their use is primarily in management of heat. The available preparation in Egypt is Thrombex, 15 milligram ampule recombinant preparation, ferrodin, platelet inhibiting agents inhibit platelet aggregation and adhesion. Prostaglandin I2 is a potent vasodilator. There is a risk of hypotension. There are only limited clinical experience with prostacyclin and a few published reports of its safety and efficacy. Signs of cloning of extracorporeal circuit are extremely dark blood, shadows or black streaks in dialyzer, foaming and with subsequent clot formation in the repeat chamber. Tearing blood in both dialyzer venous line segment is unable to continue into venous chamber but falls back into line segment. Presence of clots at the inflow dialyzer header. And these are the anticoagulation options for standard 4-hour hemodialysis sessions. And at the end, I close this talk by thanking the organizing committee and thanking chairpersons.
Thank you very much, Professor Montasser, for this very practical talk. I should declare that the incidence of thrombosis is prevailing than bleeding in dialysis because uremic bleeding was in the past history. Currently, patient died from thrombotic events, either pulmonary embolism, coronary, etc. The second point that I would like to confirm, your statement about bleeding is not always related to heparin. I remember a couple of cases, there was major bleeding because of dislodgement of the venous needle. This is why we should uncover the limb harboring the fistula, because the needle may be dislodged and there may be excessive bleeding that cannot be caught. The last point, and this is a question for you, Professor Montasser. Do you have any experience with using thrombex in dialysis?
Yes, I have an experience in using thrombex in dialysis in patients suffering from heat, and we start administration by 5 milligram from thrombex direct intra in line in arterial side, and then we monitor. It is given as a single dose at the start of dialysis, and you continue following up the instance of clotting, and you can increase those according to your observation individually for each patient.
Do you have many cases or just one case or two cases? I think
I have about 2 cases maintained on thrombex.
This is the same that we have, a couple of cases, and it's not commonly used in dialysis. The last point, as a comment, when we treat the patient with anticoagulation, we should review medications, because the patient may be treated with drugs that can increase the side effects of heparin, like, for example, ACE inhibitors. ACE inhibitor, and if the patient has tendency for hyperkalemia, ACE inhibitor or ARBs may increase the risk of hyperkalemia in dialysis patients treated with heparin. So we should be careful about drug interaction in dialysis patients. I'd like to thank you very much, Professor Montasser, for this very practical talk, and I'm leaving the mic to Professor Hani Hafiz.
Thank you.
Thank you very much, Dr. Hussein and Dr. Montasser. It was a fantastic lecture. I have some questions from the audience. One of them, what is the best regimen for anticoagulation for pregnancy, for pregnancy on dialysis?
Actually, heparin does not cross placental barrier. So heparin can be administered safely during pregnancy. No contraindication for heparin during pregnancy.
Okay. And so if the patient was already on warfarin, for example, for any reason, we could shift her safely.
Actually, as you know, warfarin is contraindicated in pregnancy, during pregnancy. So you can prescribe heparin freely during pregnancy.
Another question regarding the lipid profile disturbance in uremia. You mentioned that the European best practice prefer the low molecular weight heparin over the other preparations, especially in case of lipid profile disturbance. So the question is, what do you mean by a lipid profile disturbance in uremic patients?
In uremic patients, there is a tendency for hypertriglyceridemia and a high decrease in high-density lipoprotein cholesterol. So if you prescribe heparin for these patients, may lead to more lipid abnormalities. So if in comparison to low molecular weight heparin, there is less disturbance in lipid profile in uremic patients.
If you allow me, Professor Hani, regarding the issue of HDL in dialysis patient, it is not HDL anymore. So its protective value is lost in dialysis because the composition of HDL is completely different from the general population. And I think to put this issue as a selection criteria for any type of anticoagulation, I think it is not convincing. And in the dogma of the past that low molecular weight heparin is hazardous in dialysis, I think it is not currently working, and we use a low molecular weight heparin and we are confident of using these molecules nowadays. Do you agree about this, Dr. Montasser?
Yes, I agree.
Okay.
Thank you. Okay, thank you very, very much. And I think now we can move to the second speaker for this session. The second speaker for this session will be Professor Sameh Abu Zaid. Professor Sameh is actually the head of nephrology department at Theodore Bilhars Research Institute, and he is very active in research, specifically in the relation of يسعدنا النهارده معانا الاستاذ الدكتور سامح ابو زيد. طبعا الدكتور سامح ليه ريسيرش كتير في سبيشالي في السبلمنتس مع الرينال فيلير والبودي بيلدينج وكل الحاجات الريليتد للرياضه. لكن النهارده هو هيكلمنا في موضوع مختلف شويه ريليتد للتوبيك بتاعنا، وهو الانتي فوسفوليبيد سيندروم، لان احنا النهارده بنتكلم عن انتي كواجوليشن والثرومبوفيليا. فاعتقد ان الانتي فوسفوليبيد سيندروم is a very important aspect for all nephrologists، وكلنا يعني دلوقتي منتظرين ان نسمع البردن بتاعه على النفرولوجي من خلال الاستاذ الدكتور سامح ابو زيد. اتفضل دكتور سامح، اتفضل.
Yes.
اتفضل.
Thank you, Professor Hani, for this introduction very much. Hello, everybody. Today I'm going to talk about living with the antiphospholipid syndrome and its kidney burden. I have a flash, I think. It's not. Yes. Okay. I'm going through quickly through the categories that I'm going to talk about today, about the definition, the pathogenesis, the diagnosis and risk stratification, the renal burden, and the management of antiphospholipid syndrome. Starting by the definition, as we know, it's an autoimmune disorder characterized by vascular manifestations in the form of venous or arterial thrombosis, obstetric manifestations in the form of recurrent fetal abortion, in the presence of any or all of the antiphospholipid antibodies, which are the lupus anticoagulant, anticardiolipin, or the anti-beta-2 glycoprotein 1. It can be caused by as a primary disease or secondary to various autoimmune diseases, example as the systemic lupus. It can be classified according to its presentation, either it's asymptomatic positive antiphospholipid antibodies only, or as a thrombotic or obstetric antiphospholipid syndrome, which is the definite antiphospholipid 1+1 Sapporo criteria, which I'm going to discuss in detail in a little bit. And finally, the catastrophic antiphospholipid syndrome. As for the pathogenesis, I know it's a little bit complicated. I'll try to simplify it. In the antiphospholipid syndrome, the major target of the antiphospholipid antibodies is the beta-2 glycoprotein. However, the congenital deficiency of beta-2 glycoprotein causes binding of the antiphospholipid antibodies to the beta-2 glycoprotein 1 upregulates the expression of the prothrombotic cellular adhesive molecules such as the E-selectin and tissue factors. Furthermore, the binding of antiphospholipid antibodies and the beta-2 glycoprotein 1 suppresses the activity of tissue factor pathway inhibitors, reducing the activity of protein C activity and activates the complement system. While exposing the platelets from healthy individuals to the antiphospholipid antibodies, this increases the expression of glycoprotein 2B3A, which is the receptor for fibrinogen, and platelets in this way may play a key role in the prothrombotic interactions between the antiphospholipid antibodies and the endothelium. Neutrophil activation and release of neutrophil extracellular trap, which is called netosis, as it's seen in the left panel of the screen, may have an important element of antiphospholipid-mediated thrombosis, maybe an important element just for the mediated thrombosis, but regarding the pregnancy complication, it's due to the complement-mediated disruption of the endothelial and thromboblast function. And this explains the microvascular thrombosis that happens during pregnancy associated with the antiphospholipid antibodies. So to cumulate all this, we're going through the multiple mechanisms that we said now. Antiphospholipid activity results in an inflammation, vasculopathy, thrombosis, and pregnancy complications. As for our diagnosis and risk stratification, the revised Sapporo criteria as defined by the EULAR, we have the clinical criteria, which is in the form of vascular thrombosis, which is one or more arterial, venous, or small vessel thrombosis. The pregnancy morbidity, which is one or more fetal death at the 10th week or beyond 10th week with normal fetal morphology, one or more premature birth before the 34th week of gestation because of eclampsia or severe eclampsia or placental insufficiency, or 3 or more unexplained consecutive spontaneous abortions before the 10th week gestation. As for the laboratory criteria, the presence of one or more of our antibodies, which is the lupus anticoagulant, anticardiolipin antibody, and the anti-beta-2 glycoprotein, but it should be present on 2 separate occasions at least 12 weeks apart to have a definite diagnosis. So to have a definite antiphospholipid syndrome, we should have at least 1 clinical and 1 laboratory criteria. Simplifying in this image, the laboratory criteria, which is the anticardiolipin, the lupus anticoagulant cardiolipin, on 2 separate occasions, 12 weeks apart. The thrombotic event in the form of arterial, venous, or microvascular thrombosis, or the gestational morbidity in the form of 3 or more losses less than 10-week gestation, 1 or more losses more than 10-week gestation, or preterm birth less than 34 due to eclampsia or preeclampsia. So it's 1 laboratory plus 1 clinical criteria proves a definite antiphospholipid syndrome. As for the catastrophic antiphospholipid syndrome, which is the most severe form of antiphospholipid, it's characterized by 4 features. It's an evidence of involvement of 3 or more organs, development of manifestation in less than a week simultaneously, confirmed histopathologically by a small vessel occlusion, at least 1 organ, or a laboratory confirmation by the lupus and by the antiphospholipid antibodies. To have a definite catastrophic antiphospholipid syndrome, we should have the all 4 criteria present. If we have a probable catastrophic according to the EULAR, the all criteria except for only 2 organs instead of 3 organs affection, we can have all 4 criteria except for the absence of the laboratory confirmation at least 6 weeks apart, as mentioned before, but only due to the early death of a patient. Criteria 1, 2, 4, excluding 3, which is the confirmation by histopathology, will give us another probable catastrophic antiphospholipid syndrome. And criteria 1, 3, and 4, excluding 2, which is development of manifestation less than a week, which can be extended to more than a week, will give us another probable cause for catastrophic antiphospholipid syndrome. The risk stratification according to the antibodies and number and titr. The high risk profile is considered as a positive lupus anticoagulant on more than 2 or more occasions, at least 12 weeks apart, a double or triple antibodies combination, or a persistently high levels of antiphospholipid antibodies. But the moderate risk profile is a negative lupus anticoagulant with a moderate high titr of anticardiolipin or anti-beta-2 cardiolipin, glycoprotein, sorry. As for the low risk profile, we have a negative lupus anticoagulant again with a low, moderate anticardiolipin and low beta-2 glycoprotein 1. But the risk also increases for personal factors as are like the other systemic autoimmune disorders, the history of previous thrombotic or obstetric antiphospholipid syndrome, or the presence of the traditional cardiovascular factors like the gender, like the smoking, obesity. All these factors increase the risk, giving the high risk for antiphospholipid syndrome. These are other clinical manifestations or actually presentations that are present with the antiphospholipid syndrome but are not in the Sataro classification. They can be in the form hematological affecting the platelets, causing thrombocytopenia, which is mild between 50,000 and 150,000, or the severe, which is less common, less than 20,000. Hemolytic anemia without schistocytes, suggesting an immune-mediated hemolytic anemia, or with schistocytes, suggesting a TMA, which is the common presentation for our kidneys. As for the renal, we said we have the acute thrombotic microangiopathy or the chronic vaso-occlusive disease, which I will go to the renal burden after explaining this in detail. Other manifestations, including the cardiac valve vegetations or thickenings, dermatological as the livido reticularis or the lividoid vasculopathy. Neurologic is the cognitive dysfunction, the absence of stroke, or the subcortical white matter changes. As for the renal burden, antiphospholipid syndrome nephropathy is a vascular disease that affects glomerular tufts, vessels, interstitium. And at the same time, it has the same presentation as the thrombotic microangiopathy with fibrosis, tubule, thyroidization, focal cortical atrophy, glomerulosclerosis. The antiphospholipid syndrome nephropathy usually complicates systemic lupus, but may present also as a part of catastrophic antiphospholipid syndrome. The renal involvement can be in the form of hypertension, renal artery stenosis, renal vein thrombosis, intrarenal vasculopathy, which, as we said before, the antiphospholipid syndrome nephropathy, glomerular disease, which is very rare, antiphospholipid in the kidney transplant or in the end stage and dialysis, and in patients with systemic lupus. Hypertension. Although the etiology may be thought to be renovascular origin, it's really difficult to treat as the exact nature of the disease is poorly understood, but it can be effectively treated by anticoagulant therapy and antihypertensive drugs. Renal artery thrombosis usually presents at a new onset of severe hypertension and can present as a renal infarction, ischemic acute renal failure, or slowly progressive chronic renal failure. Other clinical features associating the renal thrombosis are the lumbar pain, localized around the renal area, hematuria, or renal failure. Sorry, I missed the part. As for the renal vein thrombosis, usually presents with a nephrotic range proteinuria, but rarely as a renal failure when the thrombosis is bilateral, and it's more frequently associated with antiphospholipid syndrome with systemic lupus. As we said before, the intrarenal vasculopathy or the antiphospholipid nephropathy is consistent histopathologically with the TMA, with acute chronic vascular occlusion. So we don't have like a pathognomic pattern or a specific pattern that says this is TMA caused by phospholipid or any other disease as hypertension, scleroderma, renal crisis. As we already know, these are all the ways to approach a TMA case. I'm not going to go through it because it's not in our topic today, but as we can see, there are many reasons, and especially the secondary TMA, as we can see, which is due to pneumococcal, cobalamin, kidney bone marrow, drugs, cancer, and the systemic disease, which one of them is the antiphospholipid syndrome. And all these have the same histopathological features. As for the glomerular involvement, which, as we said, is very rare, but some membranous cases have been reported with antiphospholipid syndrome, but overt proteinuria can be associated with renal vein thrombosis, as we mentioned earlier. As for end-stage and renal transplantation, progression to end-stage is uncommon in patients with primary APS, but it occurs with lupus nephritis and catastrophic antiphospholipid syndrome. Patients who undergo transplantation are still at risk of thrombosis at any site with a graft failure. Antiphospholipid in patients with systemic lupus, it has a prevalence of 15 to 60% with positive antiphospholipid antibodies. However, only 30 of them have the history of thrombosis or obstetric or any like the clinical manifestations of antiphospholipid syndrome. But TMA that are the typical of antiphospholipid syndrome nephropathy can be isolated with a classic lesion of lupus nephritis. Though it is the worst prognosis to have an antiphospholipid syndrome with systemic lupus, the renal biopsy must be done, but it's extremely risky. It should be done with great caution because there is increased risk of bleeding after the procedure. And it has this special treatment for the systemic lupus. Immunosuppressive drugs also can ameliorate the disease itself by MMF or cyclophosphamide, or anticoagulation may be added. Who should be generally checked for an antiphospholipid disease? Unexplained prolonged activity partial thromboplastin time during lab tests, thrombotic involvement for young age, unexplained arterial or venous thrombosis in a younger than 50 years old, recurrent thrombotic event, patients with systemic lupus, especially if they have hemolytic anemia, recurrent abortion, especially in the second, third trimesters, or early preeclampsia less than 20 weeks, or infertility. As for our management protocol, we start by preconceptional counseling, primary prophylaxis, secondary prophylaxis for the venous arterial recurrent attacks, obstetric antiphospholipid management, and the catastrophic APS. As for the preconceptional counseling, I'll go thoroughly through it, discussing the risk and the future management, delayed pregnancy. After reviewing the clinical and the laboratory profile, there is the treatment of pre-pregnancy, which is the important part. It's like postponing pregnancy is the most important if there is a thrombotic event that has occurred within the last 6 months. Postponing if systemic lupus has been active or it's hypertensive. Assess individual additional risk, the age, the clear indication regarding the degree of risk for both thrombosis and obstetric complications. Ideally, provide the women with a supply of low molecular weight heparins and lessons for self-injections. Regarding our management protocol, we have a primary prophylaxis in the antiphospholipid antibody positive patients who have no clinical or no vascular obstetric classification, the asymptomatic carriers, but they have a high risk antibody profile, like the lupus anticoagulant or the double or triple antibodies presence, or persistently high titr. Prophylactic treatment with low dose aspirin is recommended. In patients with lupus, but no history of thrombosis or pregnancy complication, if a high risk antibodies profile, prophylactic treatment with low-dose aspirin is still recommended. With a low-risk profile, the low-dose aspirin may be considered. As for non-pregnant women with a history of obstetric APS, only with or without systemic lupus, prophylactic treatment with low-dose aspirin after adequate risk-benefit evaluation is recommended. In patients with venous thrombosis, after the first attack, the treatment, the target treatment with warfarin with a target INR between 2 and 3 is recommended. Rivaroxaban and generally the direct oral anticoagulants are generally not to be used due to high risk of recurrence. In an unprovoked venous thrombosis, anticoagulation will be continued for long term, but in a provoked first venous thrombosis, it should be used for 3 to 6 months. As for a recurrent attack, we should check for the adherence of the warfarin. Frequent checking of the INR should be considered. If the INR was already 2 to 3, then we should raise the INR to 3 to 4, or change to low molecular weight may be considered. As for the arterial thrombosis, the first arterial attack recommended is warfarin also over the treatment with low-dose aspirin, but with a target preferably 3 to 4, not 2 to 3 as the venous. Treatment with warfarin plus low-dose aspirin with INR is another substitute, then elevating the INR to between 3 and 4. Again, rivaroxaban or direct oral anticoagulants are contraindicated due to high risk of recurrence. As for recurrent attacks, increase the target to INR 3 to 4, and adding low-dose aspirin or switching to low molecular weight can be considered. Secondary reflex can be simplified in this algorithm. Venous thrombosis, first attack and recurrent first attack, warfarin target INR 2 to 3. Recurrent attack, low-dose aspirin, increase the INR target to 3 to 4 or change to low molecular weight heparin. Arterial thrombosis, first attack, target INR 3 to 4 or warfarin, target INR 2 to 3 plus low-dose aspirin. Recurrent attack, we should exclude other causes, plus low-dose aspirin or change to low molecular weight heparin. As for the obstetric antiphospholipid syndrome, the high-risk antibody profile but with no history of thrombosis or pregnancy complication, treatment with low-dose aspirin is recommended. In patients with history of obstetric or thrombotic events with or without systemic lupus, history 3 or more recurrent spontaneous miscarriages less than 3 weeks gestation, or a history of fetal loss 10 or more week gestation, a low-dose aspirin plus heparin at a prophylactic dose should be considered during pregnancy. If with a history of delivery less than 34 weeks of gestation due to eclampsia or preeclampsia, low-dose aspirin or low-dose aspirin plus heparin at a prophylactic dosage is recommended. Regarding clinical non-criteria obstetric antiphospholipids, such as the presence of 2 recurrent spontaneous miscarriages instead of 3, as the criteria Sapporo says, or miscarriage less than 10th week or delivery more than 34 weeks of gestation due to preeclampsia, low-dose aspirin alone or in combination with heparin may be considered based on the patient's individual risk. As for obstetric APS treated with a prophylactic dose heparin during pregnancy, it's recommended to continue on the heparin 6 weeks after the delivery. What if we have a case of recurrent antiphospholipid or recurrent thrombosis despite low-dose aspirin plus the prophylactic heparin? Increase the heparin dose to a therapeutic dose, not a prophylactic dose, or addition of hydroxychloroquine or low-dose prednisolone in the first trimester. Use of intravenous immunoglobulin might be considered in highly selected cases. As for the catastrophic APS, the major predisposing factors are the anticoagulation, discontinuation, infection, surgery. The first line of management is combination of steroids, heparin, plasma exchange, IVIG is recommended over single agent or other combination therapies. Treatment of any triggering factor as the infections or renal malignancies. In patients with refractory catastrophic antiphospholipid syndrome, beta cell depletion with rituximab or complement inhibition with eculizumab therapies may be considered. Summarizing the protocol for treatment, we have a confirmed persistent antiphospholipid positivity. If we have a vascular thrombosis, no, we don't. Is it systemic lupus patient? Yes, then hydroxychloroquine plus or minus low-dose aspirin. If it's not systemic lupus with no vascular thrombosis, we assess the risk factors: smoking, obesity, arterial hypertension. If yes, we have these risk factors, then we will start with low-dose aspirin. If no, no treatment or an optional low-dose aspirin. But if we have a confirmed persistent antibody positivity with a vascular thrombosis, if it's venous, then a warfarin with a target INR 2 to 3. If it's an arterial, then a target INR between 3 to 4, or low-dose aspirin plus warfarin with a target INR 2 to 3. Regarding pregnancy, if we have asymptomatic, we have an optional low-dose aspirin. If we have previous thrombotic events, then it's a low-dose aspirin plus low molecular weight heparin. As for obstetric complications, if we have recurrent early miscarriages less than 10 weeks, less than 2 losses, then preconceptional low-dose aspirin. More than 3 losses, we have a preconceptional low-dose aspirin plus or minus low molecular weight heparin. If we have late complications, more than 10-week gestation, then a preconceptional low-dose aspirin plus low molecular weight heparin. And this is the time that we use the low molecular weight heparin. So according to the EULAR guidelines, injectable anticoagulation indicated in the following states: definite APS with a recurrent venous thrombosis, definite APS with a recurrent arterial thrombosis during pregnancy with a history of obstetric APS and continue 6 weeks after pregnancy, and catastrophic antiphospholipid syndrome. And why the guidelines named the low molecular weight other than the unfractionated? It's because, as Dr. Montasser said, because of these benefits, the less inhibition of platelet function, lower incidence of HIT, lower incidence of bone loss, safe during pregnancy, more practical for lung loose with a longer half-life, so it means less injections. Thank you very much.
Thank you very, very much, Dr. Sameh. Very illustrative presentation. And this stimulated many questions from the audience to you. Could we start the questions? Dr. Sameh.
Yes, sir.
Yes. The first question, is it a routine to test pregnant patient with lupus for antiphospholipid syndrome?
No, it's not a routine test. It's not in the guidelines. If I already mentioned who are the people that should be checking for antiphospholipid antibodies. If we have like recurrent miscarriages, if we have infertility, there should be a reason to check for antiphospholipid antibodies and shouldn't be a routine test.
Okay. The second question regarding warfarin toxicity.
Yes.
There are some reports of warfarin toxicity, especially in CKD, chronic kidney disease patients. So if we find that the patient started to have a rise of creatinine and started to develop, what would be the alternative to avoid warfarin toxicity?
The low molecular weight heparin is always the best alternative for the use of warfarin toxicity.
The third question, what is the best anticoagulation for hemodialysis patient who has atrial fibrillation and antiphospholipid syndrome?
I think it's the heparin, of course.
Okay. Another question regarding the familial and genetic factors in this syndrome. Is there any association, for example, with some thrombophilia like protein C, protein S deficiencies, or it is?
No, it's not. And as we already said, like the genetic deficiency itself from the beta-2 glycoprotein it's not associated with the risk of thrombosis, but the binding of the antiphospholipid antibodies itself. So even if we have a deficiency in the beta-2 cardiolipin or we have a protein C, protein S, yes, it could be an association, but it's not that. It's not that it will increase the risk because it's rare to have like two significant diseases together at the same time. They are two separate entities and two different diseases completely. And we had like the congenital deficiency of the beta-2 glycoprotein 1 does not even associate for any risk of thrombosis on itself. It's the binding of the it should be the presence of the antiphospholipid antibodies itself, which predisposes to the thrombosis.
Last question: if this patient, one of these patients, is going to be transplanted, what are the special precautions to avoid occlusion of the vascular graft?
Anticoagulation with a low molecular weight heparin, as it has been mentioned in the literature, like the best option for the transplanted patients, especially in the early 6 weeks, is the most important one is the low molecular weight heparin, which is
after that you will shift back to warfarin.
Warfarin could be warfarin could be an option and could be related to the patient history. If it's a venous thrombosis or an arterial thrombosis, if it's a venous thrombosis, then we have a target INR 2 to 3, as we said before. If it's an arterial thrombosis, then we have a target INR 3 to 4. If we have any problems with warfarin, then it's always the best option is to shift to the low molecular weight heparin and not to the direct oral or the novel oral anticoagulants, as they are not efficacious in the antiphospholipid syndrome.
Thank you very, very much. And now I give the microphone to Professor Hussein Shaisha to present the next speaker. Thank
you very much, Professor Hani. It is my pleasure to introduce Professor Muhammad Salahuddin Zaki. He is a professor and the head of internal medicine and nephrology department at the National Institute of Urology and Nephrology, Cairo. It's my pleasure to continue this very interesting meeting. Now it is my pleasure to introduce dear friend, Professor Muhammad Salahuddin Zaki. He's a professor and the head of internal medicine and nephrology department at the National Institute of Urology and Nephrology, and he's the current head of nephrology division in the Supreme Council for the Crisis Management of COVID-19 at the Egyptian Ministry of Health, and this will be a privilege to present thrombosis and the COVID. He's a member of a COVID-19 committee for nephrology population, co-author of Afran guidelines for COVID-19 renal population. He's a board member of the Scientific Committee for Egyptian Board of Nephrology, board member of the Egyptian Society of Nephrology and Transplantation. He is a head of nephrology and kidney transplantation departments at Sheikh Zayed, Ibn Sina, and others specialized hospitals. He's the founder of the Nephron Arab Centers, and moreover, he is well known in Egypt by his activities in the field of transplantation. And I think today, to hear from Professor Muhammad Salah, thrombosis and COVID-19, what do we know about it? I think it is a very exciting topic. Professor Muhammad Salah.
Thank you, Professor Hussein, for the kind introduction. It's my pleasure and honor to be with you today with my professor, Dr. Hani Hafiz, and with my very close and beloved friend, Dr. Hussein Shaisha. And of course, coming after Professor Muntasir Zaid and my dear friend, Professor Sameh, is a privilege. And thank you for the organizing company and the for such opportunity. We're going to talk about thrombosis and COVID-19. What do we know about it? As we all know that the era of the COVID-19 we are passing through has many changes. Every day we have a new discovery in this very bizarre and strange virus. I think we all know that the discovery of the relation between the COVID-19 and thrombosis has become a major discovery, and it changed the how we look about this, how we look to this disease, and how we try to manage it. Of course, this is the National Kidney Institute. Quick introduction: as we all know, coronavirus started in Wuhan, in China. Now almost about 3.6% of the infected. We all know also the zoonotic origin of the disease, bats being the primary host, but some also consider rodents, snakes, birds, whatever. Bats with the civet cat give us SARS-CoV-2 in China, SARS-CoV, SARS in China, 2003. Camel in Saudi Arabia gave us the MERS in 2012, and now thought that pangolin is the intermediate host for SARS-CoV-2 in China. Also, the first one case was in Wuhan, December 2019. Africa and Egypt, the first case was discovered in Africa in 14th of February in Egypt by Chinese tourists. The structure, as we all know, some just important things. It looks like a large pleomorphic spherical particle, has spikes, a diameter 120 nanometers, and the study showed that, like the virus that caused the SARS in 2002, SARS-CoV-2 bind to angiotensin-converting enzyme receptors on. Most of the cases were whether very mild or asymptomatic, almost 80%. Around 20% of cases needed hospitalization, and severe cases requiring ICU, almost 44%. And among those 4% who were hospitalized, among the 20% who were hospitalized, death occurred in 12% of cases. It's still a high incidence. COVID-19 and hypercoagulant state, which were the topic for today. As we all know that it's very now known for all of us that the D-dimer is become one of the more major markers for COVID-19. we always search for elevation in the D dimer. Fibrinogen elevation and is another inflammatory marker. Thrombocytopenia is not that frequent. Sometimes, even if it happened, it's mild. Coagulation profile is not consistent with DIC because we don't have thrombocytopenia here, as we may find in DIC. So, what's the mechanism of coagulopathy and pathogenesis of thrombosis in COVID-19? We have some risk factors: acute illness, bedridden, genetics, fever, diarrhea, sepsis, liver injury, CKD, COPD, heart failure, etc., malignancy. All these are risk factors. Inflammatory response, endothelial dysfunction, superimposed infection, lymphopenia increases the interleukin-6, CRP increase, inflammatory cytokines, giving us what we call the cytokine release, as we will show you in the next slide. These are risk factors with what they may cause. So the hemostatic abnormalities, pulmonary microthrombi, intravascular coagulopathy, myocardial injury, cardiac markers, elevation. So also you will find the dimer elevation, as we mentioned, FDPs, fibrin degradation products, elevation, prothrombin time prolongation, and platelets, as we mentioned, yes or no, thrombocytopenia, yes or no. Clinical outcomes: venous thromboembolism, myocardial infarction, and DIC, or disseminated intravascular coagulopathy. Here, we can see that systemic inflammation and pro-inflammatory cytokines as inducers of the prothrombotic state. Acute lung injury leads to profound inflammatory state due to a cytokine storm, macrophage endothelial activation. Systemic inflammation and sepsis will lead to, as you can see, will lead to increased pro-inflammatory cytokines, interleukin-6, interleukin-1 beta, and tissue necrosis factor alpha, leading to sepsis-induced endothelial dysfunction, endothelial cell activation, breakdown of barrier function, loss of vasomotor tone, and activation of cascade, coagulation cascade, leading to microvascular thrombus formation. Progression of COVID-19 after incubation period. Invading COVID-19 virus causes non-severe symptoms and elicits protective immune response. Elimination of the infection relies on health status and HLA haplotype of the infected individual. If health status and HLA haplotype do not eliminate the virus, the patient then enters the severe stage when strong damaging inflammatory response occurs, especially in the lungs. What this inflammatory, the aggressive inflammatory response called is the cytokine release, and it sometimes becomes a storm. But in all cases, there is cytokine release, because this is important, because we don't have to wait till the patient have that severe symptoms of the cytokine release storm to start to think about it. Actually, most or all of the extra pulmonary symptoms and signs associated with COVID-19 are related to cytokine release, even if it was not to the extent of being a storm. As you can see, and I will choose only the few effects of this cytokine release that will lead to increase the coagulopathy in this patient. As you see, fever, loss of body fluids, nausea and vomiting, again with dehydration and loss of body fluids. Acute kidney injury and renal failure is one of the causes. DIC and acute heart failure, hypofibrinogenemia, liver failure, and lastly, diarrhea. All these causes lead to the hypercoagulable state that accompanies or is associated with the COVID-19. This is a very nice specimen I would like to share with you. As we all know that the autopsy for the disease, and for some reason was forbidden for a long time by the WHO. They said that it might spread the infection and so forth. But some centers did autopsy and found these interesting findings. In New Orleans, in the United States, the autopsy here showed that on the relevant cardiopulmonary findings in the first series of autopsies in the US, with the cause of death being due to SARS-CoV-2 infection, these cases identify key pathologic states potentially contributing to severe disease and decompensation in these patients. What they found that the gross findings of the lungs showed that the lung with bilateral pulmonary edema and patches of dark hemorrhages, the heart showing extreme right atrial dilatation with straightening of the intravascular septum, and C, this is a cut section of the lung showing thrombi present within peripheral small vessels showed in the white arrow. There is microvascular obstruction, as we mentioned. Why? Because fibrin thrombi within the distended small vessels and capillaries, as you can see here, lead to the entangling of the coagulation components, leading to these increase the thrombotic effect in this patient. Also, as you can see here, there is a megakaryocyte which is entangled within the. Sorry for interruption. The internet connection was lost. Again, we were saying here that there is microvascular obstruction in the COVID-19. As you can see here, fibrin thrombi within distended small vessels and capillaries. And in this slide, you may see the megakaryocytes within small vessels and capillaries. So these fibrin fibers entangle the coagulation components and leading to thrombus formation. Pulmonary microvascular thrombosis in ARDS. This slide here to show you that the pathogenesis of thrombosis was rather similar to what we discovered back in 2002 during the SARS era and the accompanying ARDS by that time. And of course, the same cascade again is the same in SARS 1 and SARS 2. This slide shows the autopsy findings and venous thromboembolism in patients with COVID-19. It is done by Wishman, and they found out of 12 patients, there was 7 patients had deep venous thrombosis, in whom venous thromboembolism was not suspected before death. And of those 7, 4 patients died out of this venous thromboembolism. So you can see that how many patients we lose just because of this heroic complication of the COVID-19. These slides again shows here is the patchy aspect of the lung in an autopsy. How you see here the patches, the hemorrhagic patches everywhere, and here you can see the cutting surface of the lung, how it looks, and it's very also edematous and shows hemorrhagic patches everywhere. And this is the pulmonary embolism inside the lung, and this is a DVT thrombosis in all in patients with COVID-19 infection. This is autopsy for those patients. So the rates of venous thromboembolism in patients hospitalized with COVID-19, a very interesting study done over 82 patients. 30 of them were in the ICU and 52 were not in the ICU. All patients in the ICU received thromboprophylaxis, yet the incidence of venous thromboembolism was 13%. In non-hospitalized patients, most of them received thromboprophylaxis, but some were not on thromboprophylaxis, yet the venous thromboembolism rate was 4%, which is significantly lower, which leads to the assumption that the severity of thromboembolic manifestations is directly related to severity of the disease, and we will see this right now. Here is the venous and arterial thrombosis in hospitalized COVID-19 patients. You can see that the patients, at least 16% or 17% of them had one or more thromboembolic event. 8% have venous thromboembolism, pulmonary embolism, isolated DVT was not that common. Catheter-related DVT, ischemic stroke, and acute coronary syndrome was also a finding. So you can see the wide spectrum of thromboembolic manifestations that occur in the COVID-19 patients. As I mentioned before, that the VTE risk increases with COVID-19 progression. With disease progression, the factor of Virchow triad occurs simultaneously or successively. ايه هم ال three factors in Virchow triad? We have the endothelial injury, the blood flow stasis, and hypercoagulability, and all of these leads to significantly increased venous thromboembolic risk. The COVID-19 thrombotic risk, you have context-related, as we mentioned, COVID-19 severity, conventional, in the conventional wards, not in the ICU, it reaches from 6 to 14. In ICU, from 17 to 50% of the patients have such complication. Asymptomatic VTE, 15%, pulmonary embolism, stroke, and acute coronary syndrome. Some of the factors that increase the risk are related to the patient, ethnicity, age above 50, male gender versus female, cardiovascular comorbidities, and hypertension, acute coronary syndrome, renal impairment, whatever, metabolic syndrome, diabetes, obesity, previous VTE, immobilization more than 3 days, and active cancer patients and genetic thrombophilia. Coagulopathy related, massive inflammation, higher angiotensin converting enzyme concentrations, increased D-dimers, prothrombin time prolongation, DIC, and pulmonary intravascular coagulopathy, PC decrease, antithrombin also decrease, plasminogen activator inhibitor type 1 increase, and fibrin monomers increase. These are some of the important symptoms that which may lead to DVT and pulmonary embolism in these patients. حاول احط البتاعه دي في حته كده ايه تبقى بعيده شويه اهو كده كويس. We have asymmetrical pain, swelling, or discomfort present in unilateral or bilateral lower extremities, local swelling or superficial venous filling in the extremities of the catheterization side of patients with central venous catheter. This may signify DVT. Pulmonary embolism, as we all know, severe agonizing, compressing chest pain, hemoptysis, dyspnea, hypoxemia, etc., which cannot be explained just by the COVID-19 alone. It's not a finding in the conventional symptoms of the COVID-19. It is a finding that should direct us towards the thromboembolic manifestations. Risk assessment model for the identification of hospitalized medical patients at risk for venous thromboembolism, what we call the Padua prediction score. Padua prediction score is a risk assessment model where high risk of VTE is more than or equal to 4. It includes scoring system having active cancer, previous VTE, reduced mobility, already known thrombophilic condition, recent less than 1 month trauma, elderly above 70, acute myocardial infarction, infection and rheumatologic disorders, obesity with a body mass index above 30, and ongoing hormonal treatment. And in this case, the rate of VTE was those with score below 4 have low risk patients, and those above 4 are high risk patients. There is another scoring or combination of things that we may add to increase our understanding, what they call improve VTE or improve venous thromboembolism, risk stratification, and D-dimer for high risk patients. We have prior episode of VTE, thrombophilia, paralysis of the lower extremities, current malignancy, immobilization for at least 7 days, ICU or CCU admission, age more than 60 years, D-dimer, DAF, or 2 folds the upper limit of normal. Scoring here and the predicting risk is shown in the other table. Patients with improved DB more than 2 had increased VTE risk significantly, and it was statistically significant. And score improved more than 4 identified high-risk patients with a significant benefit for extended prophylaxis after hospital discharge. And this is an important issue we're going to now. So what's the treatment here? Anticoagulation, of course, treatment and COVID-19 mortality. Anticoagulation became a very standard in the protocols. And in Egypt, we had the privilege, actually, to be one of the very early countries in the entire world who implemented anticoagulation as part of the protocol of the Ministry of Health from the very beginning of the disease and the pandemic. You can see here the difference in percentages in anticoagulation use and etc. But I want to stress here that anticoagulation for those in hospital who were in anticoagulation, the risk was 29%, okay, versus 62% for those who did not receive anticoagulation. The median survival for those who received anticoagulation in hospitals and for those who are on mechanical ventilation, I'm talking about patients on mechanical ventilation, it was 21 days for patients who received anticoagulation versus only 9 days for those who did not receive these anticoagulation. As you can see here in the graphs that patients who received anticoagulation were much protected and the survival improved significant than those who are not. Quick guidelines or guidance updates for the anticoagulation use by the WHO and etc. Prevention of complications in hospitalized and critically ill patients with COVID-19. We have thromboembolism. Coagulopathy is common in patients with severe COVID-19, and both venous and arterial thromboembolism have been reported. In patients, adults, and adolescents hospitalized with COVID-19 use pharmacological prophylaxis such as low molecular weight heparin, example enoxaparin, according to local and international standards to prevent venous thromboembolism when not contraindicated. For those with contraindications, use mechanical prophylaxis, intermittent pneumatic compression devices, etc. Monitor patients with COVID-19 for signs or symptoms suggestive of thromboembolism, as we mentioned, and adverse effects. You should be careful for the adverse effects that might happen when using the anticoagulation, example, bleeding and etc. Again, this is the recommendations of the American Society of Hematology for COVID-19 and VTE anticoagulation. They said that low molecular weight heparin is superior for over the unfractionated heparin to reduce the venous thromboembolism. It's not. It's superior for a very important reason, which is to reduce the contact with the patient. As we all know that we can use the weight heparins once or maximum twice per day, while heparin you may have to go to the patient for 3 or 4 times or even more. So it is you are increasing the risk of the personnel getting infection. Also, they said that they recommended that the thromboprophylaxis should be based on local experience, because sometimes in some places, if they don't have the more costly with heparin still be the option. While if you have it, then it is better, as I mentioned before. And post-discharge thromboprophylaxis, this is very important. As we mentioned 2 slides ago, we should consider the individual patient's VTE risk factor at the time of discharge. As we said, that according to the risk, if the patient with
We lost Dr. Muhammad.
VTE risk score more than 4, so the tendency to do thromboembolism. This is again how you screen for hospitalized adults with COVID-19 should receive VTE prophylaxis per the standard of care. Extended VTE prophylaxis can be considered in patients who are at low risk for bleeding and high risk for VTE as per protocol for patients without COVID-19, and should be managed with therapeutic doses of anticoagulation therapy as per the standard care of patients without COVID-19. This is the antithrombotic therapy in patients with COVID-19, and they are all, as you may see, have very strong evidence, A3, so it is a recommended one. Clinical guidance here also for prevention, we should consider 30% of the patients who received low molecular weight heparin showed better results than those who did not receive. Prophylaxis recommendation should be modified based on the extremes of body weight, severe thrombocytopenia, example platelets below 50 or per 50,000 or below 25,000 should be kept in mind when you prescribe the low molecular weight heparin. Intermediate dose low molecular weight heparin, which is 50% of the patients, also when they took it, they showed better results. So as you may see, that improvement of the results, the improvement of the results is directly related to increasing the dose or adjusting the dose properly. So do not be hesitant to give the prophylaxis unless you have a very strong contraindication. Duration of VTE prophylaxis for hospitalized COVID-19 patients, either low molecular weight heparin, as we mentioned, 30%, or the new anticoagulants, the new oral anticoagulants. Extended post-discharge thromboprophylaxis should be considered for all hospitalized patients with COVID-19 that meet high VTE risk criteria. The duration of post-discharge thromboprophylaxis can be approximately 14 days, at least 50% of respondents, and up to 30 days in 20% of respondents. Again, VTE treatment in hospitalized COVID-19 patients, established guidelines should be used to treat patients with confirmed VTE with advantages of low molecular weight heparin in the inpatient setting over the unfractionated, and the oral anticoagulants, also the new oral anticoagulants being in the protocol. Change the anticoagulation regimen should be considered for prophylaxis or in intermediate dose to treatment dose regimen can be considered. So you have to choose whether this patient is to be put on the treatment dose or the intermediate dose according to the severity of the case. You have to keep in mind here that you are not seeing what's happening. So determining which dose you use for the patient should be very meticulously monitored to see what's going on. Which dose you use the full therapeutic dose or the intermediate dose. Also, the risk of patient bleeding, the platelet count, the coagulation profile of the patient is determinant in this. They recommended to keep the patient on anticoagulation for at least 3 months post COVID, post recovery. Okay. These are some updates. I'll go through rapidly. I think we don't have time for all of this, but again, in the chest anticoagulation, almost the same what we mentioned before. I'm giving just hints about all the written here. In the American Society or American College of Chest Physician, they recommended against the use of extended thromboprophylaxis in 2018 because they determined a net harm associated with extended thromboprophylaxis. Many hospitalized patients with COVID-19 would likely have been eligible for randomized controlled trials assessing extended prophylaxis لأنه الأمريكان Society في البداية of chest أو الأمريكان College of Chest was not in favor of using this. But then when they did the studies, they found that the extended thromboprophylaxis would result in a net benefit in patients with COVID-19 at low bleeding risk if the risk of symptomatic VTE would be above 1.8% within 35 to 40 days after hospital discharge. Despite evidence suggesting a higher risk of VTE during hospitalization in patients with COVID-19 than in patients without COVID-19, the panel of the Chest American College for Chest Medicine recommends only inpatient anticoagulation thrombosis, and that's the dilemma between the chest and the internal medicine or other other physicians dealing with. We recommend and in the Egyptian protocol now the anticoagulation become and even after discharge became a standard protocol. I will have to skip the time I passed. I'm sorry for being a long lecture. These are again the same things. We will not go through these things. Just a quick summary of the post-discharge venous thromboembolism following the hospital. They found for those which anticoagulation to choose. You can use the low molecular weight heparin according to this schedule, according to the body weight, according to the surface area, and according to the risk of the patient from the score we mentioned before. So patients with high risk should receive full dose. Those with renal impairment or low risk should monitor the dose, or you can use unfractionated heparin with as shown here. It's the same. And these are all studies. I went through all the studies that I found. I put here. It's in the Critical Care magazine. They have many studies about this issue. They all show the same results. And thank you so much. And sorry for being late again and the long session. Thank you.
Thank you very much, Professor Mohammed Salah, for this very nice aspect of COVID-19. I am a great believer in the COVID is a disease of endothelium, because this is one of the new hypotheses. It is endothelial disease. And two just short comments about the issue of hypercoagulability. In dialysis, we give ESA therapy. This is why we should be cautious when we treat the patient with erythropoietin or ESA therapies, because increasing the red cell concentrate may be associated with thrombophilia and thrombosis. This is why, if the patient is admitted and he is not treated by ESA therapy, it's better not to start ESA therapy even if the patient has anemia with acute kidney injury and COVID. But if the patient is a dialysis patient and treated already with ESA therapy, we should continue, but to be cautious about the link of erythropoietin and hypercoagulability. Although there is a case report showing that erythropoietin may be beneficial. The last point, I like this concept to be put in mind because there are some case reports, even in transplantation, infarction of the graft in the COVID. So there are 2 case reports about COVID-induced graft infarction. And if we put it in mind and we diagnose early, we may ameliorate the progression of thrombosis and salvage the graft. And I think this is a very interesting talk, full of many pathways to tackle this risk problem. At the end of the day, if we treat the patient with anticoagulation, we should follow the patient in a very wise and judicious way because the patient may bleed. So this is why we should monitor the patient. Thank you very much, Professor Muhammad Salah, for this excellent and interesting talk. And I'm leaving the mic to my Professor Hana Hafiz.
Thank you very much for اتفضل محمد كنت عايز تقول حاجه اتفضل.
Thank you, Professor Hussein, for your comment. It's very interesting, and I totally agree with you. I just want to point to something that, and it's already in the protocol for COVID-19, that patients who are on hemodialysis, you should consider increasing the dose of anticoagulation for those patients. Because as we all know, hemodialysis per se, even if the patient was not, the hematocrit of the patient is not very high, hemodialysis per se is or it's a thrombotic or prothrombotic procedure. It enhances thrombosis. So it is advised and it is recommended in the Egyptian protocol to increase heparin or increase the anticoagulation, whether heparin or low molecular weight heparins for those patients confirmed with COVID-19 on dialysis. So it is, I totally agree with you, and it is already a standard of care procedure.
I agree with you 100% about the thrombogenicity of dialysis and the great problem. We can monitor bleeding by measuring ABTT, INR, etc., bleeding time. But how to monitor thrombosis? It is difficult because in dialysis, we may measure tissue plasminogen activator inhibitor, and it is not routine and it's not available everywhere. This is why it is a difficult issue. I am sure that we are out of the schedule, out of the time, so I'm leaving the mic totally for the boss, Professor.
Thank you very much. It was a very, very interesting symposium today, dealing with all the updates in anticoagulation, a subject that we encounter every day. But today we got much academic knowledge about it. I mean, we practice it. Maybe we need some more new information that was delivered very nicely by Professor Muntasir Zaid in our everyday practice in hemodialysis modalities, and by Professor Sameh Abu Zaid by our everyday encountering of lupus patient and possibly antiphospholipid syndrome, and with Professor Muhammad Salah with the state of art about the COVID and its management. Every day we encounter this thrombotic tendency. We encounter those fistulas and vascular access that close, and we are perplexed about how to go managing those patients with vascular closure. It is not a mechanical thing just to send to the vascular surgeon, but it has much underlying medical knowledge that I hope that we in this night we got much of it. Thank you very for Sanofi for sponsoring and with the Egyptian Society of Nephrology and Transplantation this important symposium. And thank you very much, and stay safe, and hope to see you I think within 10 days in another kidney care management symposium. Thank you.
Thank you, sir.
Thank you. Thank you.